Okay. Giant cell arteritis is a really good topic because all of us see these patients and the diagnosis is still missed so many times. One of my mentors is Dr. Sohan Hayray, who's kind of my ophthalmic father, and so his office is next to mine, and so many of these concepts came out of his publications in terms of how do you tell if something is giant cell arteritis, if they have visual loss. So I'm going to cover some of these points. Some of them you will not have seen before, some of them maybe you already heard of. And here's some references. I have this in the PDF that you got. So, way back in 1960, I guess everybody has to think about this diagnosis in the elderly when they have, just starting to fail, even when they don't have vision loss. And it's really one of the few emergencies in ophthalmology that requires immediate treatment, because if it's missed, before you know it, in a few days they have bilateral profound visual loss. And so you could have saved them from going from independent living to dependent living. So it's so important to make the diagnosis early and to treat early. This is a paper, that came out of here in Malmö, Sweden. It's a very famous paper, 1971. So at that time in Malmö, 65% of the people that died here got an autopsy, no matter what. So they had a very large case series of over 1,000 patients over a year or two. And they looked at these patients' temporal arteries and found that actually about 1.6% had positive histologic evidence for giant cell. These patients weren't diagnosed when they were living as having giant cells. So in this area, it's not rare. Just people have it, they're even asymptomatic. So I think it's important for you to realize that. It's a very important paper. So the learning objectives for this is, first of all, we want to talk about why it's considered an emergency, an ocular emergency. I want everybody to know what are the common systemic and eye symptoms. And we want to talk about the laboratory and pathologic findings. And I want to also focus on what are the most common mechanisms by which this disease causes visual problems. And then we want to look at what are the objectives of the treatment. So remember, this is a granulomous inflammation of medium-sized arteries and also large arteries. So aortitis is a now more recognized problem with patients who have giant cell arteritis. The vision loss is permanent, and they often have the headache, the neck pain, the jaw claudication. Let's just talk a second about jaw claudication, because you have to know how to ask the history. A lot of people will mistaken temporomandibular joint symptoms for jaw claudication. Someone with temporomandibular joint, as soon as they start opening their jaw, as soon as they start chewing, they're having pain, sharp pain right at the joint. Jaw claudication, or claudication, is creating a metabolic demand on the muscle tissue that cannot be met by the supply of oxygen. So, people who have arterial insufficiency in their legs, the more they walk, the legs start to ache and they really become painful. So when you have jaw claudication, which is not enough blood supply to the masticatory muscles, chewing muscles, the history is they start chewing the food, and after a while, it just starts cramping and getting painful. And so sometimes I'll tell the patient why I'm asking it. I say, sometimes this disease affects the circulation to your jaw muscles, and what I would expect happen if you're having those symptoms is this and this and this. So a lot of people misdiagnose jaw claudication. So kind of be aware of how you should ask the patient. Yeah.
Jaw claudication should be considered if patients have difficulties in eating and speaking, or it's just when eating?
It's really just when you're chewing, using those muscles. And so it's really with eating. And it's slowly building as they're trying to eat. They have to stop eating because it starts becoming too achy and painful.
So people who have just little pain here, it's not
No.
considered as this.
No. You have to create a metabolic demand on the muscle where the circulation is impaired. You can't deliver enough oxygen for the demand. And scalp tenderness is the same thing with the scalp arteries, but in this case, you're not making your scalp muscles move. It's just reduced enough blood supply that it becomes painful with combing or brushing or shampooing the hair. I've had some women that came to attention when they went to the hairdresser, and they were manipulating their scalp and it was hurt. And that's a very specific symptom. There aren't too many things that cause that. Sometimes the mesenteric arteries are affected and they present to the emergency room with an acute abdomen. And the surgeons want to jump in, and open them up. But if you start getting this in the context of some of these other things, think about insufficiency of the mesenteric artery from giant cell arteritis. And these are the kind of what people call constitutional symptoms, non-specific, not feeling myself, weight loss. And then sometimes you could actually get a heart attack from giant cell arteritis affecting the coronary vessels and the aortitis. Dr. Hayray, this is kind of ironic, he's published so much on this. And about 5 years ago, he was getting out of the shower and he fell. And he went to the emergency room, and he hadn't been feeling that well anyway. And a chest x-ray showed, they just did a chest x-ray routinely, a very large aortic aneurysm. And he had a high sed rate and C-reactive protein. And we biopsied him, and he had temporal arteritis. So here's someone who's written about the most about giant cell arteritis that got the disease himself. And in his book, he wrote a beautiful book on ischemic disorders of the optic nerve. He even put his own biopsy in there to show, speaking as a patient, what it was like.
Excuse me.
Yes?
It is we ordered. Is it possible to order by time this symptom? I mean, it begins with vision loss, or
This could present either as acute vision loss, or it can present as acute abdomen. It can present as, chest pain. So that's what makes it so hard to diagnose. Is it depends on what combination of arteries are the most involved that bring the person to medical attention. And that's why I want to kind of put your radar a little bit on higher sensitivity, not to biopsy every single person, but start thinking about this.
For the scalp tenderness,
Yes.
How much should we press, or
Yeah.
how many seconds?
No, right away it'll be tender when
Right
you
away.
press on it. Yeah. It's just an ischemic scalp that's tender to touch. Don't expect the temporal artery to be prominent. It can be, but a lot of patients, they just have a normal looking temporal artery. So even though you see this in the book, it's not going to be there all the time. And remember that this granulomatous inflammation is in the media of the muscular coat of the wall and the internal elastic lamina. So gradually the wall thickens and the lumen becomes smaller and smaller and then occludes. And this is a regular H&E stain, and this is elastic stain. And with the H&E stain, you may not see multinucleated giant cells in every case. It may just be lymphocytic infiltration. But with an elastic stain, you'll see a breakup of the internal elastic lamina. And some pathologists will see a specimen that doesn't have any inflammatory cells, but only has a destruction of the internal elastic lamina. And most pathologists feel that that is still a positive biopsy, even though there's not active inflammation. It may be active in other arteries of the body, but in that specimen, this is a footprint of previous inflammation that they don't think any other disease caused that. Atherosclerosis doesn't cause that. So sometimes they'll report that as what's called healed arteritis, but don't let that make you think that it's inactive. It just means it's inactive in that part of the biopsy. It still could be active, in other parts. And then this is from JAMA journal article in 2006, and even more is known about this now, but what I wanted to call your attention is that this is now considered a T-cell mediated response, where there are a lot of chemokines released, and it's mainly IL-6, as the interleukin 6 is a major player. And at the end of the lecture, we'll talk about some of the newer treatments. Some of the monoclonal antibodies to IL-6 receptor is supplementing steroid therapy now to psilocybin is the new one that was approved in the last year or so. Also, interesting enough, if you look at an MRI carefully, you can see signs of giant cell arteritis. So what do you see on an MRI scan? So first of all, this is without contrast and with contrast. And this is the temporal artery. You see that enhancement around the wall? I'm going to show you better examples. So here's a patient that had no enhancement on the right half, but on the left half, you see these vessels. See that enhancement? That's actually an MRI sign of granulomatous enhancement of the temporal artery and occipital artery on an MRI scan. Now, Dr. Hammer and Rafi are leading the pack here. I'm not going to tell you too much, but they have a special way of imaging the temporal arteries that show inflammation in the wall before you even do a biopsy, non-invasively. So that's the cusp. If you can image these vessels in vivo and help localize where you should biopsy, that's a log unit ahead of the game. So these are, and ultrasound also has been used. Here's another example just showing the MRI enhancement. With ultrasound, here's a normal temporal artery and here's a high-frequency ultrasound. You see this area of decreased reflectivity of ultrasound. People call that the halo sign. And so again, similar to that last picture, that area with ultrasound looks darker or low reflective. So this is the MRI halo, so to speak, and this is the ultrasound halo, this dark area around the lumen with ultrasound. Yes?
Do you mean that you still need to biopsy, or is it enough to diagnose with this?
Good question. The question is, well, if you see that, do you really need to biopsy? I'm going to say yes. I'll tell you why. Here's what happens if you don't biopsy. You're certain you've got the diagnosis. Okay. You put the patient on high-dose steroids. The internal medicine person is helping you manage it. Maybe they take over the management. They've got them on high-dose steroids for months. They're starting to get side effects. It's hard to get them tapered off. And now they're saying, well, maybe they really didn't have giant cell because we don't have a biopsy. So the reason why we almost always try to get a biopsy to have a histologic diagnosis is because the enthusiasm for how much they have the diagnosis, I can tell you it fades exponentially as they have side effects from the steroids. So it's kind of your insurance policy to keep people realizing this is giant cell arteritis, So maybe this will change in a couple of years as we know how sensitive and specific these tests are. And it might help us know which patients should be biopsied more than others, but right now, we really need a biopsy. Do you agree?
Yes.
Yeah, totally.
This is for the future, I think.
I think it remains to be seen. We're hopeful. But the technique that the group in Lund is using is even more sensitive, probably, and more higher resolution than this. Maybe you can coax them to tell you more about it. But. So the visual symptoms. Here's another important point that Dr. Hayray published. If you take all the patients with a correct diagnosis, 20% or 1/5 have none of those systemic complaints. They only presented with vision loss. You ask them, the best historian, you really question them, they have nothing else. So we call that occult giant cell arteritis. They're only affecting the ocular arteries. So just because they don't have systemic symptoms, don't discount that they don't have the disease. Very important point. Some of the symptoms are very important to recognize. If you get a patient that has amaurotic episodes in one eye, and you get the history that it happens when they get standing up from sitting position or from lying down, that's an extremely important amaurotic sign that's caused by a giant cell. And the reason what's happening is that, let's say the posterior ciliary arteries that supply the choroid and optic nerve, those are the arteries that are affected the most. As the lumen is narrowing, you have a decreased blood supply, but it's sufficient at baseline to deliver enough oxygen to the optic nerve. But with sudden drops in perfusion pressure, sudden drops in blood pressure from orthostatic changes, they get amaurosis. And so if you get that history, that's someone who in the next few days is ready to occlude and have permanent blindness. So jump on that. When you get a patient with amaurosis, I always ask about positional changes and then get a centrate and C-reactive protein. Very, very important sign. Yes?
When we stand up from...
Anything that would cause a transient drop in blood pressure. Yes?
I was wondering in the first part if you want to have ocular symptoms, is it more unlikely that the biopsy will be negative?
Yeah, good question. Good question.
Artery affected.
Right, so the question is, well, if they only have occult giant cell, only ocular symptoms, does that mean the temporal artery biopsy is likely to not be positive? Actually not. It just shows up in the artery. It's a likely location to be there. It doesn't mean it's less likely. Yeah. And then another interesting one is transient double vision. So although giant cell arteritis could cause a third nerve palsy, pupil involving, it also can cause transient diplopia because the muscular artery, which also comes off the ophthalmic artery, supplies the eye muscles. So if that artery is affected, just like you have transient visual loss, you can have transient double vision from decreased blood supply to the muscle itself, not the nerve. And then the big one is, of course, if you get a history of an older person having abrupt, profound loss in one eye or both eyes, or in rapid succession, that's just, you should be on the path of giant cell in terms of your differential. I want to show you a case that I thought was very interesting. So this is an 81-year-old who awoke with vision loss in the right eye, profound vision loss. So it's hand motion vision. The outside automated perimetry showed a lot of loss with a little bit of preservation in the center, but still hand motion. This was the kinetic visual field. This eye, this eye went to hand motion, but initially it had 20/70, 20/40. Sed rate was high, and the C-reactive protein was high. And there were other symptoms. I want to show you what the fundus picture looks like. So this was a symptomatic eye. Now I want you to try to figure out what is going on here. I'm going to help you. We're going to look at this eye in greater magnification. So first of all, how about the nerve? We'll get to this in just a second. How about the nerve? We've got nerve fiber layer hemorrhages, swollen or not swollen? It's swollen. Is it pale or not pale? Hard to tell. Doesn't look white. So we've got a swollen nerve with profound loss in an 80-something-year-old. Now the question is, what is this? Huh? Exudates. No, it doesn't look like exudates. Exudates would look wider and more discrete. I'm going to show you this next to another patient I saw that had something that wasn't exactly the same. We'll come back to this. This is another patient that, okay, but wait a second. This one had a central retinal artery occlusion and 2 cilioretinal arteries that supplied this area. That's why it's spared. Now, I want you to try to understand what this is, because what that is what that is. Huh? Axoplasm. You go to the head of the class. Why did you say axoplasm? That's very good.
Flow with the Einstein's class. So it's like flow of the sensitive.
Yes. So that the surviving part of the retina has axoplasm and it hits the dead part of the retina. So it's backing up. That's what it looks like on OCT right at that border. And so that is like a axoplasm hitting the wall. Okay? It can't go any further. And so, but that was a cilioretinal artery sparing, because those were the normal axoplasm that couldn't get past the dead part of the retina. Now let's go back to our case, this one. So you see in this case, this was a cilioretinal artery that was blocked. And the normal central retinal artery area is hitting this area of occlusion. Now, I want you to look at the angiogram here too. Now, you need to know how to interpret an angiogram for giant cell arteritis. Very, very important. Very underutilized. The reason the angiogram is so important is that, remember what's differentiating non-arteritic AION from AION. Remember, non-arteritic AION, which you're going to hear from Dr. Arnold this afternoon, is a hypoperfusion, not a vascular occlusion. Giant cell arteritis is an occlusion of a posterior ciliary artery, either the medial or the lateral or both, that supply the optic nerve head. And what else do they supply? The choroid. So if you see an arteritic AION, you will, during the first 10 to 14 days of the vision loss, you will always see a large section of the choroid not filling because of an occlusion of the posterior ciliary artery that's supplying the optic nerve. I'm going to show you more examples. So you see there's a whole non-filling of the choroid here. See, the central retinal artery is filling. Cilioretinal artery is affected because where does that come from? It comes from the posterior ciliary artery. So if you ever see a posterior ciliary artery occlusion in AION, that is giant cell arteritis until proven otherwise. Remember that. Cilioretinal artery occlusion plus AION, that's an occlusion of a posterior ciliary artery, and that's giant cell arteritis. That's almost, incontrovertible evidence that they're going to have it. Very, very important for you to recognize. You don't get branch artery occlusions. All the papers in the literature are really cilioretinal arteries if you look carefully at the fundus photos. So you get this non-filling of the whole area supplied by the posterior ciliary artery. And we're using a technique called laser speckle flowography. You're going to start hearing more about it in the coming years. It's a way of measuring blood flow to the optic nerve, choroid, and retina in real time with near-infrared light. So it's no flashes, 4 seconds during the heartbeat. And what you see here, this is a normal eye. Won't take long on this. Ah. Well, I guess I won't be able to show you that, sorry. What it does is able to measure the dynamics of blood flow in all these beds at each of these pixels at the same time. So you can see what happens in a normal eye during the cardiac cycle in an area over the vein, over the artery, over the choroid. And the laser produces a speckle pattern that's imaged in the plane of the retina. And any moving particles, like blood cells, blur the speckle pattern in that area in proportion to how fast it's moving. So it's a way of directly measuring movement of red blood cells in every pixel in the image. And so here's a patient who had occlusion, giant cell arteritis with an occlusion of the lateral posterior ciliary artery. So here's the fovea, and you see this is an even filling. And this is a fluorescein. And you can see what it looks like with a laser speckle. There's hardly no flow here. So it's a way of non-invasively, we're doing it at the same time as a fluorescein, we're thinking it's going to replace the fluorescein. And here's 9 cases where you can see blue is low flow. So these are arteritic AIONs. You see this massive decrease in blood flow to the choroid. And so remember that in the case of arteritic, this is an actual infarct of the optic nerve head due to inclusion of one or more posterior ciliary arteries.
Can we,
Yes?
before we, some friends, before you said transit diplopia, can refer to giant cell arteritis.
Yes.
How much time should it be transit?
Oh.
Minutes?
Less than a minute.
In a minute.
Less than a minute.
Less than a minute.
Good question. The question is, if you do get transient diplopia, how long does it last for? It doesn't last very long at all. So you don't always see a pale nerve head. It depends on the degree of ischemia or infarct. If it's complete infarct, it's going to be pale swelling. But it may vary depending on how much decrease in blood flow there is to the nerve head. Now here's an example of a pallid optic nerve edema. That's almost pathognomonic also for acute arteritic AION. You don't see that in non-arteritic AION. And of course it becomes pale and cupped over time. It becomes cupped because the glial cells are infarcted too. So remember, to get cupping, it's not just loss of the axons, it's glial and axon loss. And you can get the same type of field defects as non-arteritic. It can be just altitudinal, it doesn't have to be profound. Just to quickly review, what time are we finishing?
5.
How much?
10 minutes.
10 minutes.
10 minutes, okay. Just to review the circulation. Remember, in the cavernous sinus, the ophthalmic artery comes off the carotid right around that location of the optic canal. And that ophthalmic artery often forms what's called a common branch, which gives rise to the central retinal artery and the posterior ciliary artery. Here's a lateral posterior ciliary artery. Here's a medial posterior ciliary artery derived from the ophthalmic. But I'm going to come back to this common branch in just a minute. This is a fluorescein angiogram of a normal eye video. I'm going to play it again. So the choroid fills pretty much right away. It may be patchy, but it fills immediately. Here's another example. Choroid fills first, then artery. Here's a patient with giant cell arteritis. The central retinal artery is filling first. There's hardly no choroidal fillings. Now it's just starting to come up some slow flow. And that's kind of what you saw in the snapshots of the fluorescein angiogram from before. Some of these are reversed, so this is the area of no filling. Here's 5 seconds after injection. There's hardly no filling of the choroid. Here's an interesting slide. So here's a patient who had occlusion of the posterior ciliary artery that supplied this whole area of the choroid. And we did a multifocal ERG on that patient. And you can see the waveforms are down in that same area because what does the posterior ciliary artery supply? The optic nerve and the photoreceptors. So actually, you wouldn't know that because there's so much optic nerve damage are not seen in that area anyway. But if you did an MERG, you would find that it's down in those areas of ischemia. Here's another example. That whole area is not perfusing. The MERG of that eye is abnormal in that area, normal in the other eye. And as I said, if you see a cilioretinal artery occlusion in combination with AION, that is giant cell arteritis. Here's another example.
But the slide before,
Yes?
we just have a choroidal non-perfusion, but he has no optic neuritia, no ischemic occlusion.
Yes. Yes, there was a swollen nerve and profound loss, remember? The nerve was swollen too.
But the scene, the visual field correlate to the choroidal change.
No, there was profound visual field loss, if you remember that first case. Remember, it was hardly just a small island was left.
I mean the slide before was just the last one. This one.
Oh, this just the electrical response from the outer retina. That doesn't say anything about the optic nerve. It's another marker of posterior ciliary artery occlusion. Now, here's another really important pearl I want you to take away. This is what Dr. Hayrie taught me. Every elderly patient that has a central retinal artery occlusion should get a fluorescein angiogram. Why? We know the central retinal artery is occluded. You don't need a fluorescein angiogram to show that. Because you're looking for signs of giant cell arteritis, which will be choroidal non-filling with a central retinal artery occlusion. And remember I showed you in that anatomy slide that I said I would come back to it, the common branch. So many people have a common branch that comes off the ophthalmic artery that supplies both the central retinal artery and one of the posterior ciliary arteries. So every case that's been known and reported where there's a central retinal artery occlusion due to giant cell arteritis is from a common branch occlusion that not only occludes the central retinal artery but also one of the posterior ciliary arteries. So here's a central retinal artery occlusion and a swollen nerve, and the choroid is affected. So you don't want to miss giant cell arteritis causing a central retinal artery occlusion. But the only way you'll know is by a fluorescein, because you'll see abnormal or loss of filling of the choroid.
But
Very
if it is a probe in the common branch,
Pardon?
if it's just a probe close in the common branch,
Yes. It's due to occlusion of the common branch.
why it is giant cell arteritis?
Why?
Yeah.
Why?
A clot, just a clot obstruct the common branch.
It's because most embolic forms of central retinal artery don't occur in that location. The reason is that if you look at Dr. Hayray's anatomic histologic analysis, the central retinal artery is the narrowest where it enters the optic nerve sheath. And most of the emboli, that's where it is. That's why when you look in the eye, you don't normally see the embolism. So the common branch is usually large enough that it doesn't get an embolic occlusion. Yes?
And if we see the cherry red spot sign, is it good to make a fluorescein angiography?
Yes, I think it is. And you might check the SED rate and C-reactive protein, and maybe if that's elevated, then you'll do a fluorescein. But think about giant cell arteritis in every case over 60 years old, as a cause of a central retinal artery occlusion. Now, one other thing. If you see a central retinal artery occlusion, but there's a cilio-retinal artery sparing, it's almost completely never giant cell arteritis. Okay? If you spare the cilio-retinal artery in the context of a central retinal artery occlusion, it's not giant cell arteritis, because you would always affect the cilio-retinal artery. It's a really important point. Yes?
It doesn't help to do blood with some in this case. Or is it to be not
Well, often what I'll do is I'll do the SED rate and C-reactive protein. And if it's borderline or high, I'll do a fluorescein angiogram. Yeah. Yes? Okay. Oh, yeah. Yeah. I'm going to get to that in just a second. The question is, if you get a normal SED rate in CRP, how comfortable should you be they don't have giant cell? I'm going to get back to that. In fact, I'll get to it right now. This is a graph of the erythrocyte sedimentation rate in males and females. And the black dots is the normal distribution by age. This is the SED rate on this axis in millimeters per hour. And the open symbols are the patients that had giant cell arteritis. And part of the answer to your question lies right here. So look at this. Here's a patient that had, a SED rate of 8. Now what's interesting about these patients that have the diagnosis, when they're treated with prednisone, they may go down to 2. So their normal SED rate was 2, but it was 8. These patients, yes, they're up in the 100. Those are very abnormal, but the SED rate by itself is not very sensitive because of the wide range that's present in normals, even adjusted for age and gender and sex. Now here's the C-reactive protein on this axis in milligrams per deciliter, and the erythrocyte sedimentation rate. And the black dots are all the normals. And see these ones that I've colored in red? Okay, those had sedimentation rate in, quote, the normal range in here, but C-reactive protein above the normal range. So that's why the combination is very important. So the next question you're going to ask me, can you have a normal C-reactive protein in giant cell arteritis? And the answer is yes, but we do not advertise it. Otherwise, you'll be doing temporal artery biopsies every day of your life. So it can happen. If you have a high clinical suspicion, do a biopsy, but most of the time, if the SED rate and C-reactive protein are both normal. No, the C-reactive protein is the first to go up. It's a very acute phase. And it's the first to go down with treatment, too. The SED rate may take a week or 2 to go down. But the C-reactive protein is very acute phase. And then some people are also doing platelet counts, because platelet is elevated too, is another sign. So, just to end up, the objectives of steroid treatment. First of all, there's usually no recovery of vision in the involved eye. You're trying to prevent further loss or involvement of the other eye. And you want to prevent other ischemic complications of the disease. Now, here's an important question that people ask. Number one, should I use IV steroids or oral steroids? And how long after I start treatment can I be sure that nothing bad's going to happen to the patient? They're not going to lose more vision. It's really not been found that IV steroids is any better than high-dose oral steroids. What we do is an outpatient, we give 1 gram of methylprednisolone before they leave. As soon as I suspect it, I give them a gram, and they send them home with oral steroids. So at least you're getting them in. Now let's say you start them on steroids right away. Think of giant cell arteritis as a speeding train. You can't stop it right in its track. You can still lose vision within 5 days of starting adequate treatment. You have to tell a patient that. But we've never had a patient that after 5 days of treatment then lost vision. So the critical time period is first 5 days after adequate treatment. Even in spite of that, your best efforts, you diagnose them, they still might go blind. That's the tragedy. But you need to tell the patient that so they're not thinking, you did something wrong. There's still risk. And then, as I mentioned, this tocilizumab is the new treatment on the block that rheumatologists are using in combination of steroids to reduce the total steroid dose and how fast you can taper. And it's just recently been approved. It's extremely expensive. And the question is whether it really is going to be used routinely or not to reduce the course of the steroids. And this is just showing, this is 6 patients showing the response after days after treating steroid of the C-reactive protein and the SED rate. And just see how fast the C-reactive protein comes down. I want you to see that, within days. Whereas the SED rate, it's slower to come down. So we still use both, but you should see a response to the CRP right away. So the take-home points. Giant cell is one of the few ocular emergencies you're going to see. And if you don't diagnose it in a timely fashion, they have a high chance of going bilaterally blind. Most of the time, the blindness is caused by occlusion of the posterior ciliary arteries that supply both the optic nerve and the choroid. Giant cell may cause visual symptoms and blindness without systemic symptoms. That's what we call it, cold giant cell arteritis. And these are the systemic symptoms we talked about. And you should use the ESR and the CRP and probably platelets to help in diagnosis and monitoring. You really need a biopsy for definitive diagnosis. And many patients need to stay on some maintenance dose. Not everybody gets off steroids. They may have to be on 5 milligrams. So you're not only following the symptoms, but the C-reactive protein and the SED rate. So you want those to go down to the lowest level, and then you start tapering and monitoring, make sure they're not climbing back up again. Yes?
How quickly do you want a biopsy after you start steroids?
Good question. So remember I talked about that healed arteritis? You can see evidence of destruction of the internal elastic lamina anytime afterwards. So this whole notion you have to biopsy within 1 week or 2 weeks, even we see the active inflammation months after treatment. So it's not a reason not to do a biopsy. Okay? Don't say, oh, you've been on steroids too long, it's no use doing a biopsy. I still think you should do a biopsy no matter what, no matter how long it's been or how long they've been on steroids. Good question.
But we should start with cortisone before biopsy,
Yes.
First day, not wait.
Yes, unless they have a high risk of complications. Let's say they're a brittle diabetic, and then you have to talk to the patient. So you're weighing risks here. And if you are going to start, you might have to have your internist help you manage their diabetes. So, it depends on how high is your clinical suspicion, but most of the time, if you're going to do a biopsy, most people will put them on steroids right away. Because if they go blind, by the time you diagnose them and do the biopsy and you didn't start steroids, you're screwed, right? And the patient's screwed too, so.
How do you correlate the biopsy findings with the different
Okay.
fields you place different
I don't think there is any correlation. I don't think there's any correlation with the biopsy result and the manifestations. Oh, no, it's not positive all the time. There are skip areas, and also it may be in one side, not the other. So the question is, what if the first side's negative and you have a high clinical suspicion? Sometimes we'll biopsy the other side. Sometimes if the clinical suspicion is high enough or they have angiographic findings, even if the biopsy is negative, we'll treat them as if they have giant cell, if you have a real high clinical suspicion. So I don't think the biopsy, a negative biopsy is not 100% sensitive. And so you have to be aware of that. Remember, you're just sampling one artery of all the arteries. So that's why other non-invasive measures like what you're doing in lung is so important, because it could not only help localize where to do the biopsy, but you get a better idea of where the involvement is. Okay, good.
Good. Thank you so much.
Yeah, you're welcome.
Thank you. Då är det fika till 3:05. Då är det kaffe.